Gopal ji, vanakkam, Vice President Margo.
Good evening, sir. Good evening, sir.
Gopal, good evening, Gopal ji.
Good evening, good evening. Ramesh, sir. Good evening, sir.
Vanakkam,
sir. Vanakkam.
Good evening, sir. Good evening, sir.
Welcome, Gopal.
Good evening, sir. Good evening.
Everybody is in the car.
Gopal ji.
Yes, Anna, நீங்க என்ன எங்க கார்ல எங்க போயிட்டு இருக்கீங்க?
நீங்க எங்க போயிட்டு இருக்கீங்க?
கோபால் என்ன புதுசா தாடி மீசல வச்சு.
கோபால பார்த்தானே ஸ்ரீலங்கா போற மாதிரி தெரியுது எனக்கு.
ஆமா. தோனி. ஆமா.
திரு ஜாயின் பண்ணல நானு.
ராஜ்குமார். உங்க தலைக்கு பின்னாடி பெரிய ஒளிவட்டமா தெரியுது.
வெல்கம் ராஜ்குமார்.
சார் குட் ஈவினிங் சார். எல்லா கார்ல தான் இருக்கீங்க போலயே சார்.
சார் குட் ஈவினிங் சார். குட் ஈவினிங் எல்லாருக்கும்.
குட் ஈவினிங், குட் ஈவினிங்.
ஆமா.
எனக்கு பஸ் இன்னொரு
ராஜ்குமார் எங்க இருக்கீங்க?
Sorry.
ராஜ்குமார்
சார்
எங்க இருக்கீங்க?
பஸ் இன்னும் half an hour பஸ் ஏறணும். half an hour.
Gopal, sorry, we'll start the program. Is that okay with everyone? Because
we'll start. Okay.
Okay. Good evening, everyone. We are very happy to have this wonderful program B2B, which is back to basics, the diagnosis by observation, the power of the meaningful look by none other than Professor Tangavel sir. Now I request our student Dr. Rajkumar to start the program with the pediatrician spirit. Dr. Rajkumar? Okay. Fine. Dr. Rajkumar? Fine. I will say the pediatrician.
I'll start.
Yeah.
So. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you. Now I request our secretary, Dr. Narmada, to guide over the inauguration proceedings of the program. Over to Dr. Narmada.
Thiru sir, good evening. Thank you so much for allowing me to take over the proceedings and welcome all for this first session of B2B Back to Basics. And actually, I am very excited because being a student of Dr. Tangavel sir, I am very happy that I am able to listen to his session and learn from him again. We all will be ever students for him. And this is a very unique session planned under the Presidential Action Plan of Dr. Rajendran sir. And I'm sure every one of us will be benefited. Even in all the exams we take, it's only the basics that is going to help us in our practice. Looking forward for a very exciting session with Dr. Tangavel sir. And thank you, Dr. Rajendran sir, for the Presidential Action Plan. And Dr. Tirumurugan sir for so beautifully coordinating all the thing and taking the efforts to do this. Thank you all the elite members who have joined the program today. And thank you, dearest delegates. Without you, no program is a success. And you have made IAP TNSC one of the most sought out academic programs in IAP TNSC. Thank you so much for the same. I apologize for the video because I'm traveling for yet another very interesting academic discussion which is going to happen tomorrow in Pondicherry. Thank you so much, all of you. And now I hand over to Dr. Rajendran sir for his presidential address.
Thank you, Dr. Narmada. Respected today's Chief Guest, Dr. Ramesh Kumar. He was Central IAP President 2022, and he was so dynamic, and he set a benchmark for that national IAP. I welcome Dr. Ramesh Kumar sir, and so I welcome you, sir.
Yes, thank you.
Yeah, I welcome Dr. Tangavel sir. He's teachers of teacher, and he's a well-renowned teacher all over India. and I welcome for this back to basics B2B, and I welcome sir. And I welcome Dr. Srinivasan sir. Is again the teachers of teacher, and is now back to basics. Like he is now student. All meetings he is attending, and I welcome Dr. Srinivasan sir, and I welcome scientific advisor and our presidential candidate 2026, Dr. Singarvelu sir, and I welcome academic coordinator Dr. Tirumurugan Saren, and Secretary Dr. Narmada, Dr. Rajkumar, and I welcome all the central as well as state IAP members. It is one of the things we are coined for the B2B. This is back to basics by Dr. Thangavelu sir. The main aim of this B2B is we have to take the basic things to our practicing pediatricians. That's the main aim. Actually, I asked Dr. Thangavelu sir which topic do you want to go for our teaching program. He clearly told I want to go back to the basics for our practicing pediatricians. That's only that area we are gray area and neglected also. So actually I really happy that he is going to continue this program every month on third Sunday. Today is actually for some unavoidable sacraments we are keeping in Saturday. Next month onwards will be on every Sunday 8 to 9:30. And without wasting time, I request Dr. Tirumurugan to proceed further. Thank you very much.
Thank you, sir. I now request our beloved Dr. Singaravelu, Vice President IAP 2024, to introduce. He doesn't need an introduction, but still to welcome our chief guest of the day, Dr. Ramesh Kumar, sir, and ask him to inaugurate the session. Singaravelu, sir.
Thank you, Thiru. Thank you, President. Respected dignitaries on the platform, Zoom platform. Our beloved chief guest, Dr. Ramesh Kumar, doesn't need any introduction. The only thing is whenever we request, whatever we need in various capacity as a secretary and as a president, he was always helpful to all the IAPNs. That is his nature. See, we were planning this within a very short period, and everybody wanted, that is a uniqueness when we decided to whom we have to select to inaugurate. None other than the very dynamic administrator come academician, and who is heading a very prestigious institution at Cochin. So none other than Ramesh ji is ideal for inaugurate this session as a chief guest. We are really thankful, sir, and grateful to you, sir. We welcome you on behalf of the entire team, because this, as our president told, president has got lot of action plan. So along with Thiru, and we are coordinating several programs for which Thangavelu sir known for his academics, and he always points about academics. That too, he concentrated more about basics. So, however, you are the big practitioners. Without basics, nothing could be made. That he decided. And thank you, sir. Whatever assignment academics we in whether in the central IAP, he is with me for having the Triple E program, which is going very well. 2 episodes we have finished. Like that, this is taking. So we are extremely thankful and ably supported by my teacher of teachers, Professor Srinivasan sir, and all office bearers of Central State IAP, past presidents. They are only in the Zoom platform. Others are in YouTube, all the viewers. And I am, without, as our president told, without wasting much time, we are very, very happy to welcome our past national IAP president, one of the very dynamic person who has done lot of things. If I start telling, I'll be taking more time. That is, he had, in spite of the COVID, had a wonderful period. He brought a lot of academics, which was released as a book, which is still useful to all the practitioners. He brought the vaccine, everything, so many things he did. This will speak of him ever. Thank you. With this, I hand over to Thiru to invite our chief guest.
Yes, sir. Thank you very much, sir. Now I request our chief guest, Professor Ramesh Kumar, sir, to say a few words and inaugurate the session.
Can I proceed?
Yes, sir. Please, sir. Please, sir.
Okay. Thanks, my dear IAPians in IAP Tamil Nadu. And it's back to basic, but I'm back to my second home in IAP, or certainly my second home. That's So greetings to the president, my beloved friend, Dr. Rajendran, the most dynamic president and secretary. I have seen him as a secretary, not much as a president recently. And again, the president-elect, Dr. Somasundaram, and the immediate past president, Dr. Balashankar. And of course, Gopal Subramanian, the dynamo from the south, as the vice president, the ever vibrant Dr. Namada as the honorary secretary, and Dr. Rajkumar as the treasurer. And again, Tirumurugan, always there as the tech savvy Thiru with their call. I was always hearing, that's what I was saying, Thiru. So, Thiru.
Thank you, sir. Thank you, sir. Thank you.
And of course, the seniors out here, Dr. Srinivasan, always there in any academic platform. The first person we look for in our Zoom meetings are whether Srinivasan there is there or not. We are blessed by his presence always. And again, Thangavelu sir, we always cherish, as Namada said, cherish his presence. And here you see, he has taken this back to basics. That speaks about his confidence as a clinician. Only a learned, very confident clinician can take up this mantle of taking up this. Others will shy away from such a topic. I have seen that happening many times. And my dear friend, my Tanjavur leader, Dr. Shingaravelu, and I mean, I would love to see these activities happening again and again, and in his 2027, under his presidency again, we all will be really privileged it's happening. So I would love to see, and I wish that it's happening. And my good friends out here, Dr. Sudhagar, again, Jayavardhane, and C. Devi, as well as Balaji, the coordinators, then, of course, Amal Raj and Annamale, I have seen the EB members, Ismail, Tirumurugan, as well as Ramesh Babu. And again, I would say it's always fair to have a word of, gratitude as well as remembrance to Dr. Parthasarathi at any moment before I start talking about Tamil Nadu, because he was one person, at no time I miss whenever I'm in Chennai, I used to meet him, because he has been patronizing many of our youngsters and grooming them and making them confident about themselves in their academic domains. And again, Dr. Sendil, Dr. Shivapragasham, and all others. Of course, I cannot forget my other Tamil Nadu friends like Dr. Venkadeswaran, Dr. Tirumale Kolundu from the south, as well as Dr. Velusamy from Erode, and our Shanmukham Erode. Many, I feel, and many of my friends, Ismail from Coimbatore, and I will try to take him from my time, Dr. Somashekar, as well as Dr. Guna Singh. They are always there, taking me around, and I mean, this is a great opportunity or a privilege for me to be with my great friends in IAP Tamil Nadu, and I'm so happy that I got an opportunity to greet you all and see you on at least on the Zoom, and with the great academicians around, Dr. Ramachandran also here, PRC, he's here. We all revered their academics and their clinical abilities, acumen, always, and being from such a high volume institutes like Madras Medical College or ICH and other Stanley and all institutes which speaks about such a high volume cases and all variety of cases, there should be the team leaders, basically the ones who take up this mantle. And well, friends, this is your IAP action plan, especially with Dr. Rajendran. Congratulate you for taking up these initiatives. And back to basics is something which I always cherish when I am taking. Currently, I have been a teacher. Maybe the last 3-4 years, I'm aggressive, very much into it. The DNBs around in my institute. So this basically. Whenever you understand, many of them, they start from the niche, they see the X-ray and they start talking about what is happening. They never look at the chest movements or even for a consultation. Maybe in medical colleges it may be happening, but outside it may not be happening. So it's always to see good that inspection basically is something which you have taken up, and as we always understand, this is the first impression, and the early clues come from inspection. The first inspection, that makes a lot of difference, right from maybe, I still remember 40 years back when I was in the medical school at Kottayam. many times this cyanosis may be used because the population maybe the color fair, you don't get cyanosis that easily appreciated, and many times we got caught for not recognizing cyanosis, or many times clubbing, in early clubbing, we were just confused whether it was clubbing or not, the angle. I mean, especially early clubbing is so difficult to. So, but basically, if inspection gives you some confidence about going ahead, and it helps identify the issues where how to proceed with the movements. And basically, it's the something which we require here is we don't require armamentarium here. I mean, this all, but basically, from my perspective, I will see that a clinician's eye and maximum torch is required, a light source is required, nothing else is required for, and this is the best clinical examination in a COVID time, in a situation like a COVID time, or even when you go and see a patient with a very sick patient with chicken pox or other things, the mask, and all those things without, maybe where there are limitations or barriers when you cannot handle the patient so that easily. So inspection certainly can give you a good impression. As a child who is taken off his clothes and seeing the chest movements, but then the habit must be there, having gone to the, and then once you are in a hurry, you may basically look at the inspection, and I mean, it requires trained eyes, that is very important, experience, that is second important, and most important is what you say, like attention to detail, because these are certain things which a teacher like Dr. Thangavelu or Dr. Srinivasan must have inculcated in their PRC, might have inculcated in their students, and which may be sadly a little bit missing the current scenario or current tribe of not teachers. I mean, the students are not that inclined. Probably that's what I have learned from the medical college teachers. So it's no. It's that one that detects subtle that may indicate serious anomalies. So that's something which very many a time inspection happens. So basically, I appreciate the thought that inspection must be given, that at least that aspect of clinical examination is properly highlighted, and that is being given the due importance. And many times we know that it cannot give much, but when it is there as an inspection as a main topic, and our students or juniors will start thinking about inspection, what is there so much work about, and this topic is happening. So at least it comes into their mind that this is something which is virtuous, and I appreciate Thangavelu sir, or really congratulate him for taking this topic. And again, I mean, IAP TNSC, as I have seen, is brimming with activities over the last, maybe I have been watching from 2018, and every year the new benchmark is being set. Probably that you didn't have that. I mean, the social media and other aspects are giving you much more coherence and the bonding, and it's a widespread out state. It's not like Kerala, where you can travel 4 hours from one part, 5 hours one part of the other part. So that inherent geographical difficulties, challenges were there. I mean, meeting physically in the academic session. So the Zoom has given, or the virtual platforms have given that edge where that makes you a little more coming together and deciding and moving ahead with a very, very clear platform, and where all these discussions will come. You meet each other, exchange pleasantries, have some fun at the beginning. That keeps you, I think, bonded and more closer to each other. I mean, closer to the heart, not to the more than the brains. So that also is important. That means that the team is making good, and that should be reflected in our the organizational levels, at least when the election are happening. And I'm pretty sure that my dear friend Dr. Shingarvelu will take us to a different level to all aspects in the coming. Tamil Nadu IAP under Dr. Rajendran and Dr. Gopal, as well as the president-elect coming as Somasundaram, Narmada, as well as youngsters, Tirumurugan and Rajkumar and all those people, and with the EBM-based guidance. So all those that you have got such a team of young seasoned seniors, veterans, and the youngsters, and this is always most important. I am so happy to see that the spaces are being those. We are giving space to the youngsters also to come up big on this. I can see three of the youngsters the names there who are presenting today. So happy that the sessions are happening big. Tamil Nadu IAP is going great guns, and academics is going great. The clinical acumen is being sharpened by this type of back to basics things. But then everything has to be balanced. So other activities are also coming up. And again, the organization is also getting strengthened by this academics as well as the other activities happening alongside. So happy for that. My friends in Tamil Nadu are really enjoying the time in IAP. I am also finding it a little difficult with my time, even here also, but always there with you for all the activities, for all your wherever my guidance is required in all your academics or organizational aspects, that you live on elections, everything I am there. Myself and my friends in Kerala, like Sukumaran sir, Sachi, and MKC sir, as well as all our youngsters, like Dr. Riaz, current president, Nandakumar studied in, the president-elect studied in Chennai only. Riaz has got a lot of friends. So they are all the young team who are coming up, and they are all will be definitely there with you. I'm very sure about it. And Dr. Jose and all our contemporary leaders, all will be there. Krishna Mohan, all will be there with you. So we are really together, but start sailing strongly, make it as a robust team. The team should gel over the academics in the next 6 months. You should gel over this, over the academics, come together, plan. Then later on, that gives the momentum to hit hard. And then only you are at a, and you start at a one step ahead. Start blocking itself is a higher level. So congratulations and all the best. And I'm so proud to officially launch the Back to Basic B2B program or the E2B academic initiative from on this platform under the guidance of Dr. Thangavelu, under the presidentship of Dr. Rajendran, and with seniors like Srinivasan sir, PRC, and all around, and Singavaru sir as the scientific advisor all around, and all you are my good friends and my good friends on the platform, the IAP platform all around. All my best wishes to you. Good times with you in IAP as well as in the professional life and personal life. So let us all come good in our journey ahead. Thank you.
Thank you so much, Ramesh. Wonderfully.
Thank you.
Thank you very much, Sri, for those wonderful words of wisdom, encouragement, and friendship and camaraderie. It was very, very nice of you to join us. I think we are all waiting to move on to the program, and I think I just hope that our relationship blossoms further and become and fosters forever. And we are very happy to have had you here today. So thank you very much. Now I request Professor Srinivasan, Professor Thangavelu sir to start the program and enlighten us on something which is so important, the inspection. I still remember my MRCP case actually. My exam was CNS case, and then the examiner told, do not examine the CNS, but don't test the patient. Just look up and then just give me the findings. And I was very excited when I heard sir was going to do the same. So thank you very much, sir. Over to Sir Thangavelu, sir. Thank you.
Thank you, Thiru, for comparing, mistake me for Srinivasan sir. Looking at ahead, I think you have mistaken both of us. But inside
so both of you have been my examiners.
Focus of B2B is community pediatrician, who is the frontline soldier in the health services. He'll be the base in the health provided by pyramid. He's very busy, spends nearly 10 to 12 hours in his clinic and small hospitals every day. He's easily approachable, charge less, available for long hours. Only problem with him is he has less chance of further learning if he's not attached to teaching institution or regularly attending CMEs. He is pressed for time and he can't stretch his time further. If he can provide a deep look or powerful look by providing visuals, followed by visual-oriented text, not only he will be benefited, whole community network also is strengthened. This is the essence of B2B, back to basics and bridge the gap.
Kevin didn't come. How was the
Probably.
Priya madam, please mute ma'am. Priya ma'am. Priya, please mute.
Yes, yes, I'll mute.
Just another 2-3 minutes, I'll complete the introduction. I'll request Dr. Saranya to try present his the PPT from her side. This is the essence of B2B, back to basics and bridge the gap. Probably I'm the right person because I had the opportunity to work in about 12 hours in remote areas without electricity or bus service where only transport is lorry before I entered teaching institutions. I have a team of young pediatricians in their 30s to fine-tune our presentations. I would like to thank IAP TNSC team led by Professor K. Rajendran, very energetic, enthusiastic person. He did wonders during the COVID time. Supported able by Narmada, Rajkumar, Thirumurugan, Gopal, and the brilliant set of IAP seniors, Professor Balashankar and Dr. Sumusnaram. I'm overwhelmed with happiness by the presence of Professor Singaravelu, my friend, a charming and sincere teacher, and Dr. Ramesh Kumar, my dear friend and great president, brought the STD, Standard Technical Guidelines, for all the practitioners, teachers, and students as a practical reference manual. My guru, Professor Srinivasan, my dear friend, Dr. P. Ramchandran, I welcome you all. Last but not least, because of laryngitis, my voice is husky. I'm not telling secrets. Whenever my voice is not clear, my team members will take over. With this, I request Dr. Saranya, our team member, to present the PPT from our side. Dr. Saranya. Yeah, I'll just move the next slide. Dr. Saranya is graduate from Kilpaw Medical College, did a DN from Mehta Hospital, currently working as a pediatrician at Mehta Hospital. She got an award, a CTS award, for a presentation viral etiology of underweight children admitted with ARE in the Indian Pediatric Intensive Care Unit. She has authored a chapter on ASCII book in pediatrics for postgraduate practitioners. Next slide. Mohammad Ismail got his MBBS from Madurai Medical College, DNB from St. Philomena's Hospital, Bangalore, currently working as pediatric registrar. He has also authored a chapter in the book ASCII in Pediatrics for postgraduates and practitioners. He was also part of ASCII exam team in IAP Medical Education chapter. Sudiksha got his graduation from PIMS, Pondicherry Institute of Medical Sciences, called gold medal in microbiology, right person for this basics. Got his MD Pediatrics from Siddhartha Institute, currently working as pediatric registrar in Mehta Hospital. Next slide. So we are going to share a lot of videos and visuals. So I sincerely salute those who continue to help the recovery of sick kids by sharing their pain and visuals to enrich the medical knowledge, because we are using their visuals and videos for the recovery of sick kids as well as for the medical knowledge. See, the next 60 minutes, I divided into 5 components. First component is meaningful to look at the videos. It will be a resemblance of seeing a patient in the ER. Next is stridor, upper airway obstruction, V's lower airway obstruction, grand lung parenchymal disease, and emergency preparedness. The topics is the courtesy given by IAP ALS group. Next slide. Of course, I told this earlier itself. Probably we'll be spending some 65 minutes for discussion, 10 minutes for the question answer from the audience. Next slide. So generally, most of the seniors like me will ask the parents to bring the child inside, particularly underweight kids. When they come inside the doctor's clinic, to remove the shirt or just raise the shirt to look for us to have a good look at the chest and abdomen. Because the diagnosis lying there, as Dr. Ramesh said, we can get a lot of details from just meaningful inspection. First, count the respiratory rate for 30 seconds. Any increased work of breathing, like noisy breathing, retractions, flaring of the LNSA, which indicates increased work of breathing. Third, if possible, saturation. Fourth is any alteration in mental status. If we apply these 4 steps, we can classify our patient into 4 categories. A normal well child, normal rate, normal work of breathing, level of consciousness good, saturation normal. Second one is effortless tachypnea. The child has got increased respiratory rate, but work of breathing is normal. Is effortless tachypnea, classically seen in diabetic ketoacidosis. Second is rate increase, work of breathing also increases respiratory distress. If the child has got increased rate, increased work of breathing, in addition has altered mental status, that is a feature of respiratory failure. These are all the physiological status coined by Paul's group. Next slide. So what is the rate? Naturally, the question will arise. WHO has given a very clear definitions. To call tachypnea less than 2 months, more than 60 is tachypnea. 2 months to 12 months, it is more than 50. 12 months to 5 years, it is more than 40. Next slide. So generally, neurologist has the fancy of classifying disease into upper motor neuron, lower motor neuron. Of course, we can apply the same rule for the respiratory system also. Upper airway disease, where the tachypnea will be there, but significant retraction, suprasternal, sternal retraction, and stridor. Classical example is croup. If the child has mild tachypnea but subcostal intercostal retraction in weeks, it is lower airway obstruction like asthma or bronchiolitis. The child has got high rate, 70, 80 like that, plus retractions, current, it is indicative of parenchymal or pleural disease, like pneumonia or empyema. And along with this parenchymal pleural disease and current, the child also has some murmur, whether it's systolic or diastolic, no issues, or gallop, poor sweating, disprobate tachycardia. This indicates probably we are dealing with, though it is an unusual cause, the cause which we should not miss is that is cardiogenic shock and pulmonary edema. Next slide. So to define noisy breathing, which are audible without stethoscope, stride is a harsh, loud inspiratory sound caused by partial obstruction of the airway, causing turbulent airflow. Peace is the musical expiratory sound. Grunt is the moaning expiratory sound. Next slide. Now, we will look at videos which will have a deep look or meaningful look, as if we are seeing a patient in the ER, to watch the videos and to get as much of information as possible. Next slide. Dr. Sudiksha, can you comment about the video? This is the child who has come to our ER. We are just having a meaningful look at it. Can you get what all the information you obtained from this? Dr. Sudiksha?
Yes, sir. Good evening, sir. So in this video, we see a 3-year-old child in respiratory distress. This can be made out because of the tachypnea. There is increased respiratory rate. There is sternal retractions, and we can hear a very harsh, high-pitched, monophonic inspiratory sound. So it is most probably a case of croup, and this sound is called stridor. This is the next picture is of the same child after she has received adrenaline nebulization.
Thank you. I just have a doubt, Sudiksha.
Yes, sir.
How did you decide it's inspiratory sound?
So
I think
usually, sir?
How do you decide is inspiration looking at the video? So mostly any sound which appears during retractions, can you go back, Saranya? Meaning any sound which occurs during inspiration. Inspiration is reflected by presence of retractions, is inspiration. Can you just play for 5 seconds?
Yes, sir.
Sound occurs during inspiration. Okay, enough, I think. Next slide. Thank you. Thank you. Thanks, Sudiksha. This is a child who has recurrent wheezing episodes, used to come to ER in the middle of the nights. Saranya, can you just describe the finding you make by inspection?
The child is alert, looking around. The child has tachypnea, subcostal and intercostal retraction, and we can also see the alar nasi flaring. She also has minimal expiratory wheeze, which is not much audible in the video. She is in respiratory distress. Whereas in the next video, the child is in severe distress. He is not even able to lie down. The child is supported on the parent's lap. We can see severe retractions, head is bobbing. There is altered mental status. The child is in respiratory failure.
Thank you, Sandhya. So it's the lower airway disease, the respiratory distress, as well as the respiratory failure. Next slide. Can you increase the volume, Sandhya?
Sir, that is the maximum, sir.
Dr. Ismat, you heard a sound. You're seeing the child. Can you describe the clinical details of the child?
Thank you, sir. Here in this video, we are seeing an infant who is being resuscitated with an oxygen non-rebreathable mask, which is a sick infant. He is making grunting sounds, which is an expiratory moaning sound. We can also observe there is tachypnea observed by the rapid respiratory rate. And the retractions we cannot make out because it's obscured by the O2 reservoir bag. We can observe there is an upward fixed gaze indicating there is an altered mental status. So putting all this together, this is a child in respiratory failure, most probably due to the severe pneumonia consolidation or an empyema, because grunt is invariably due to parenchymal pathology.
Again, grunt is also an impending respiratory failure. Grunt
Impending.
it has to be immediately admitted to ICU, otherwise we'll see the child in cardiac arrest next few seconds.
Yes.
In fact, this child was treated outside, received 3 nebulizations, steroids, IV magnesium sulfate, and referred as refractory asthma. 3 things which were different in this child. One is the saturation was, room air saturation was normal. The child has got deep and rapid breathing, but not much of retraction, very minimal retractions. We don't hear any noisy breathing. The deep and rapid respiration, no noisy breathing, minimal retraction. These are the features to suggest effortless tachypnea. Usually it can be seen in benign states like high fever, but it may also reflect this is a child who presented with glycosuria and ketonuria as diabetic ketoacidosis. So if we apply these points, we may not be a child with diabetic ketoacidosis, which will be differentiated by the following 3 points: deep and rapid breathing, minimal noisy breathing, minimal retractions, no noisy breathing, and no adventitious sound. Saturation may remain reasonably normal. Next slide. So this is what we have already shown. Effortless tachypnea, increased rate, normal orca breathing. Respiratory distress, increased rate, increased orca breathing. Respiratory failure, increased rate, increased orca breathing, and altered mental status. Next slide. This child had a very minimal findings, just diarrhea, but surprisingly very much lethargic, disproportionate to the amount of dehydration. Ismath, can you comment about the video?
In this video, we are seeing an infant who was referred as a case of diarrhea. As we can see, we have to go very closely to see and keenly observe whether to make sure whether the child is breathing or not. So this is what we call it as shallow breathing. This child is also looking lethargic and having rapid respiratory rate. And so this turned out to be a case of an IEM. So this suggests the child is in respiratory failure and needs immediate intubation and higher care with mechanical ventilation. We can compare to the next video. In this video, we can clearly see the both phases of respiration as inspiration as expiration clearly. There is no tachypnea, there is no chest indrawing, and the work of breathing is normal. So this is a normal breathing pattern, just for comparison with the shallow breathing, to identify between sick and non-sick babies.
Next slide. These are all some of the serious respiratory patterns. If you happen to see a child in this appearance, immediately child needs respiratory support and referral. This is courtesy Dr. Professor Ramesh Babu from Dharmaburi. This child has a midline foreign body. You can see the altered mental status, severe head bobbing, retractions, and also a smooth bulging in the right supra infraclavicular area indicative of septal emphysema. This is a child with midline foreign body in the trachea. Next video. Here, the child shows head bobbing. Head bobbing is indicate very severe form of increased orca breathing. Head bobbing is indicate the child will land up in respiratory failure, respiratory arrest in the next few minutes. Look at these 2 videos. The first one is showing a good abdominal, good chest rise. Abdomen is retracting. Can you show the first video?
Yes.
Chest rise is good. abdomen is retracting. Abdomen movement is because of diaphragm. So this is a diaphragmatic palsy causing cease breathing. Chest raise means intercostals are good. This is a child with GBS who recovered, but diaphragm weakness persisted. The next, the bottom video is, you can see the abdominal movement are very good. Chest movements are very inconspicuous. Abdomen movement are good because diaphragm function is good. Chest raise is not there because the child had a spinal cord injury causing intercostal weakness. So these two are cease breathing. Once we come across this, immediately we have to support with back mask ventilation and try to shift the child to tertiary center. And they may need intubation and mechanical ventilation. Next slide. Now we move on to the second component of the CM talk. This is about strider, upper airway obstruction strider. Next slide. Dr. Sudiksha, you are going to take over this component, this part of the discussion. Can you explain various types of strider we come across depending on the level of breathing, level of obstruction?
Yes, sir. So, stridor is a high-pitched, harsh, inspiratory sound produced due to upper airway obstruction. This can be inspiratory, biphasic, or expiratory. More commonly, inspiratory, which is caused when the obstruction is above the level of the glottis. And we see biphasic stridor when the level of obstruction in the subglottis or just at the level of the carina. Below the level of the carina, if there is obstruction, we see an expiratory sound. Most commonly, we hear the inspiratory sound. So, in
You mentioned about strider. Generally, strider children will not come with fever. Anything else you want to tell, Sudiksha? Please, go ahead.
Sir?
Anything else you want to tell about this slide?
So, generally, if we have to
so that means inspiratory strider is obstruction glottis and above. Biphasic strider is between from glottis to carina. Below the carina, it will present with expiratory V's. Next slide. If the child has got stridor but no fever, what are the differential diagnosis, Sudiksha? Sudiksha is last. Oh, okay, till Sudiksha join, I'll just proceed with this. If the child has got stridor but there is no fever, means these are the three important differential diagnoses. Hypocalcemia, foreign body airway causing obstruction at the level of trachea or glottis, and angiogenetic edema. Among these three, very, very important is foreign body airway. So any child, sudden onset of stridor, no fever, foreign body has to be excluded. Sudiksha, once you join, please.
Ma'am, sir, her connection is lost, sir. She's trying to join.
Okay. In the meantime, I'll just continue. Next slide. So we saw stridor without fever. Here we see stridor with high-grade fever and sick-looking child. Then there are three differential diagnoses. So, Sudiksha, are you in? So three differential diagnoses are acute epiglottitis, bacterial tracheitis, and retropharyngeal abscess. Among these three, acute epiglottitis is the worst, very, very serious diagnosis. Here, the children will be in the age group above 3 years, 3 to 6 years, drooling of saliva, high fever, and the stridor will be very soft stridor. We have to go very close to hear this stridor, unlike the stridor of croup, which is harsh and can be heard even away from the child. Bacterial tracheitis is a complication of croup. Generally, croup children are expected to improve within 48 hours. They don't recover, continues to have fever and stridor. Then the bacterial tracheitis diagnosis established. Retropharyngeal abscess is retropharyngeal space is potentially thin space. When we cut multiple lymphoid follicles, if it is infected, it forms an abscess. Child present with severe retractions of the neck and stridor, where retropharyngeal abscess are diagnosed. These are all diagnosed by X-ray lateral view in earlier days. Nowadays, CT neck get a very good clinical picture. Sudiksha, are you in?
Yes,
Sir,
sir. Yes, sir. Sorry, sir. There was a power cut.
No problem. So now what is the commonest cause of commonest cause of stridor?
In children, the commonest cause of stridor is acute laryngotracheobronchitis, otherwise known as croup. It causes acute onset stridor in the age group from 6 months to 3 years of age. It is associated with prodromal symptoms like cough, rhinorrhea, and usually upper respiratory tract symptoms, and they usually have a normal level of consciousness and not associated with drooling. So in this case, how we manage the child is never separate the child from the mother, don't stimulate the child, and postpone IV access or throat examination. Everything should be delivered in a non-threatening manner. We check the pulse oximetry and oxygen in a non-threatening manner it is supposed to be given. And we administer adrenaline nebulization in a dose of 0.5 ml per kg to a maximum of 5 ml. For a child weighing 10 kg, we can just give plain adrenaline of 5 ml, preferably administered by the mother herself. And this should be given along with 10 to 15 liters of oxygen. And one thing we need to emphasize here is the adrenaline is to be given only via nebulization and not by IV or IM route. In case we are not able to give oxygen of 10 to 15 liter per minute, it is better to administer intravenous or intramuscular dexamethasone in a dose of 0.6 mg per kg, maximum dose of 8 mg, and then refer the child to a higher center.
Thank you. Thank you very much. Yeah, you stress the importance of adrenaline. The new nurse may not know the importance. She should not accidentally give us IM or IV. So I think it should be done under the supervision of the pediatrician. Thank you. So, Surisha, next slide. When you will not worry even after seeing stridor, her face will look like what you see in the emoji. So when you won't worry about stridor.
So stridor in a child who is feeding well with normal growth, and if it is disappearing on the prone position and increased on the supine position and while crying and present chronically, that is within the first few weeks of birth and for a long time, is usually due to laryngomalacia. In this case, we need not worry.
Thank you. Next slide. So when you will actually worry and act very fast.
If stridor occurs in a well child of acute onset, that is in a child who was well even an hour ago, with dramatic onset associated with respiratory distress, choking, and cyanosis, is due to a foreign body. So we have to worry, and one has to act fast because it kills the child. For example, in this picture here, we see a small child who presented with stridor and respiratory distress, and we discovered a foreign body, that is a fish, in the glottis. In the chest X-ray below, we can see that the left hemithorax is hyperaerated and there is mediastinal shift towards the right side, and we can observe the bronchovascular markings as well. So this shows obstructive emphysema of the left side due to the impacted foreign body.
Excellent. Sudiksha, when will you refer the child with stridor immediately?
Any child presenting with stridor, if she has a hemangioma, the first look of a hemangioma, we should suspect a subglottic
After
hemangioma.
looking at the child, what are the clues you are going to give the audience?
So the presence of hemangioma, this indicates there could be subglottic hemangiomal involvement. So we have to refer the child. In the second picture, if we observe any unimmunized child, especially older child, presenting with stridor, and when we observe the throat, we find a adenotonsillitis with a gray pseudomembrane. It is diphtheria. So in this case, we need to take adequate precautions while examining the child, like wearing gloves and mask, and have to refer the child immediately. In the third picture, here we see a child with a toxic look, and he has the characteristic sniffing posture, and some amount of drooling of saliva is also apparent. In this case, acute onset stridor with this clinical picture is suggestive of acute epiglottitis. This child also has to be referred immediately. In the fourth picture, we can see X-ray lateral neck showing a foreign body. So this child also presented with acute onset, and they gave a history that the child was playing with the toys, and then there was sudden onset of coughing and choking. This case also, it has to be referred because it warrants urgent bronchoscopy and removal of the foreign body. The next picture shows an infant. The grandmother said that child was having an incessant cry and they had administered grape water, after which child developed stridor and was continuously crying. When they came to our ER, on examination, we found that the child was in distress and we found necrotic patches in the oral cavity. So this is because of corrosive burn. Later it was found that in the bottle used for the grape water, there was accidental fillage of the corrosive and they had administered by mistake. So this corrosive poisoning also can cause stridor. This also requires urgent referral. The next picture, we can see a small child who presented with distress and stridor. What we can observe here is a swelling in the neck. Whenever there is swelling in the front or the side of the neck, we need to think of an abscess. It could be parapharyngeal or retropharyngeal abscess. So this child, we had intubated, and then as you can see in the last picture, 3 ml of pus was drained. So this abscess also led to stridor. These all in these situations, we definitely have to refer the child as quickly as possible.
I'd like to thank Dr. PRC. He was the one when we are in ICH. This child was seen with corrosive poisoning. Okay. What about the next one? Next X-rays.
So on the left, we see a chest X-ray. Here we can see normal expansion on the left side. Whereas on the right side, we can observe mediastinal widening. So this was the X-ray of an adolescent female. She presented with stridor, and on X-ray we found this mediastinal widening. This mediastinal mass later turned out to be a lymphoma. So whenever there is we see any mediastinal mass in the X-ray, we have to think of immediate referral and further investigations to find out the cause.
Up to what age a mediastinal shadow may be normal? In thymus may be normally seen up to 18 months. So
Yes.
up to 18 months, a superior mediastinal shadow may be normal in an asymptomatic child. Okay, thank you, Sudiksha. Next slide. Okay, we got a lot of wonderful information from our younger colleague, Dr. Sudiksha. Now we move on to the lower air obstruction Bs, which will be presented by Dr. Saranya. Over to Saranya.
To reiterate the levels of obstruction and corresponding added sounds with a pictorial representation, if the obstruction is at the level of the glottis, we hear an inspiratory stridor. If it is between the glottis and carina, then we will hear stridor during both inspiration and expiration. This is called a biphasic stridor. If the obstruction is in the medium or small airways, we call it a wheeze. Here we can see a picture of normal bronchial tube as well as an infant bronchial tube of an asthmatic. The lumen is obstructed and narrowed by the swelling, mucus, and also there is tightening of the smooth muscles. This causes resistance to the movement of the air, causing the high-pitched musical whistling sound of wheeze. When we see a child with wheeze, the most important thing is to get a good clinical history and examination. First episode of wheeze observed in an infant is an acute viral bronchiolitis. The diagnosis is mainly clinical. The chest X-ray might show hyperinflation with air trapping, or sometimes it can even be normal. Management of first time.
Can you use the cursor? Saranya, can you use the cursor to explain the pictures?
Yes, sir. Management of first time wheezer, usually acute bronchiolitis, will include oxygen, IV fluids, and a trial with salbutamol or 3% NaCl. Any child with acute onset of breathlessness without fever, before treating it as wheeze, we have to rule out whether there is any foreign body ingestion which can cause obstructive emphysema as explained earlier, or if we see a child who has disproportionate tachycardia to that of the distress, there is forehead sweating. On auscultation, we find there is gallop, murmur, and the child looks lethargic. We take a chest X-ray and we see cardiomegaly. Then we should suspect myocarditis with cardiac failure and treat it as such. So, as I said earlier, history and examination in a child with wheeze is very important. We have to know whether the onset of wheeze is insidious or sudden. How many days did the child have wheeze? Was it daytime? Symptoms are more in the day or in the night? Whether the cough is dry or wet? how many days a month does a child have wheeze, whether it is restricted to only a particular season or the child has wheeze throughout the year. Any associated symptoms are present or whether it is associated with fever. And very importantly, if there is activity limitation in the child due to this frequent wheezing episodes, whether there is school absenteeism or playtime for the child is restricted, and we should also identify what are the triggers which trigger the wheeze in the child, whether any viral infection or exposure to smoke, dust or food or in response to activity or exercise. And we should also know whether the child has any other allergic symptoms like atopic dermatitis or allergic rhinitis, and whether there is history of asthma in parents. It is very important that documentation of airflow limitation is done by a physician. That is whether there was presence of wheeze one or more times in the past and whether it was relieved by giving a beta-2 agonist inhalation. So a child comes to us with wheeze. We have documented that it is definitely wheeze. Then if the child is in minimal distress, then inhalation treatment is the mainstay in the treatment of wheezing. In clinics where we do not have pressurized oxygen support, because for giving nebulization, we require 10 to 15 liters of oxygen. Nebulization always should be done with oxygen to prevent the VQ mismatch. In such cases, then the inhaled short-acting beta agonist SABA, usually salbutamol, using a MDI and spacer, can be used as an initial reliever treatment until the symptoms subside. It can be divided into two, till 4 years and above 4 years. Until 4 years, we can use a MDI along with a spacer and mask. If the child is above 4 years, just the MDI and spacer will be enough. Now I will show you. In this video, we can see a child sitting comfortably in mother's lap. MDI is being delivered with spacer and a paper cup by a health professional. In resource-poor setting where it is not possible to provide masks for each baby, paper mask is a very good alternative. It provides the necessary seal required and we can change the paper cup for each child. We have to hold the MDI with thumb and other fingers, place it in the spacer and observe. We need to observe the child and ask the child to breathe normally. This is very important. The child should not hyperventilate. We should ask him to breathe normally and we have to wait till the child is breathing normally into the mask. We have to see whether the valve is opening and closing for 3 seconds. Then we will deliver the puff. Count the valve opening and closing for 10 times or wait for 15 seconds. Then deliver the next breath. Depending on the severity, we can deliver 2 puffs to 6 puffs at an interval of 15 seconds. This is for emergency distress control. Here the same child, we can see how well he has improved. The advantages of spacer over nebulization is only less time is required. It does not require any oxygen support and we are giving only 1/4 the dose of the nebulization. This is for emergency distress control. We will go a little further into GINA guidelines to decide when to refer to an asthma specialist. So, if there is a physician documented recurrent wheeze for more than 3 episodes per year or there are severe episodes, uncontrolled symptoms, then a trial of inhaled corticosteroids can be given. The dose of which is daily dose of inhaled corticosteroids. What we are using is budesonide, 100 microgram, 1 puff twice a day for 3 months. If there is a good response, then we can stop ICS after 3 months and follow up. If the symptoms are not well controlled after 3 months of low dose budesonide, then the following should be checked. Ask the parent to bring the MDI, spacer and mask every time during review and ask them to demonstrate what technique they are using. whether they are adhering to the inhaled medications normally, whether there is any other comorbidity, or there is any ongoing exposure to allergen which needs to be removed. Only after correcting all this, and we ask them to continue 3 months more of low dose butyric. Even if after that the symptoms persist, the child should be referred to a asthma specialist for further management.
Of course, Saranya, below 5 years, we don't label as asthma, we label only as under 5 years, which may be due to multiple reasons. Only after 5 years, the terminology of asthma is used. Okay, now we move on to the third component of the discussion, lung parenchymal fluid disorders. I invite Dr. Mohammed Ismat to discuss this topic.
Thank you, sir. This is a video of the child we saw previously. There's no sound in this. The child was having grunting sounds. Basically, to describe what is a grunt is a moaning expiratory sound. Why it happens is it's because the child is struggling to breathe.
I can just imitate.
Yes.
It's something like a moaning sound during expiration.
Expiration phase. So child is struggling to breathe against a partially closed glottis so that it can generate some end expiratory pressure. A grunt invariably indicates that the lesion is at the parenchymal level or pleural level. So obviously the most common causes will be a severe pneumonia or an empyema. Well, we can also have a few non-respiratory causes for grunt. The child may be having grunting in cases of cardiogenic shock, myocarditis, where there is pulmonary edema also. Or for abdomen cause, when the child is having a tense, painful abdomen, like in instances of peritonitis, we can, and appendicitis, we can, or severe appendicitis, we can have the child grunting. Next slide. Now we are moving on to one of the most common day-to-day pediatric diseases, that is pneumonia. WHO has specifically classified pneumonia into 3 categories, as no pneumonia, pneumonia, and severe pneumonia. So, for example, when a child presents to our OPD with only symptoms of cough and cold, but there is no, when you examine the child, there is no fast breathing, no chest indrawing, child is fairly active and playing. So we can, WHO states that we can manage the child with supportive symptomatic treatment with the home care advice, and to give the red flag signs and warning signs to the parents when to come back. And if the child comes with the same symptoms of cough and cold, that is upper respiratory symptoms, along with child is having fast breathing with or without chest indrawing, this should be classified as pneumonia, but not very severe. So this can be treated as depending on the clinical situation of the child, as either oral antibiotic therapy at home, or if child is having poor oral intake but not that much sick, the child, and is a very younger child, we can admit the child in a smaller hospital where it does not need to have a PACU support. We can manage with IV antibiotics and oxygen support with or without IV fluids based on the oral intake. And the third category is severe pneumonia, where we should, it's very imperative that we should pick up immediately. The child will be presenting with the same signs of with not very severe normal pneumonia, that is fast breathing, chest indrawing. Along with it, the child will also have few danger signs, that is persistent vomiting, poor oral intake, altered mental status in the form of either lethargy, unconscious, etc. And as stated before, the child may be having grunting or stridor as other abnormal respiratory sounds, or child may be having severe malnutrition. In this case, we should immediately transport the child to a tertiary care center where there is PACU support. The child should be transported preferably and accompanied by the pediatrician with O2 support, along with the bag and mask as well as brain circuit at hand to immediately resuscitate. And child should have had first dose of IV antibiotic and on IV fluid support. So child should reach the tertiary care center for higher respiratory support. Now we will be seeing the antibiotic therapy as both oral and parenteral, as according to the IAP guidelines, what antibiotic we should choose. For oral therapy for pneumonia, remember that for a less than 3 months age group, child should be always admitted and treated in the hospital, and child it's not warranted to treat at home if you pick up pneumonia. For 3 months to 5 years toddler age group, the first line antibiotic is always oral amoxicillin. And the second line is we can choose co-amoxiclav or one of cefpodoxime or cefuroxime. The doses as mentioned. And when we are suspecting a possible etiological agent is Staph aureus, that is, the child may be presenting post-measles state or post-influenza state, or with a rapidly worsening of symptoms, and or there is a coexisting skin and soft tissue infection, we can add on with linezolid, or along with cefuroxime or coamoxiclav. For more than 5 years age group, the first line is again same as above, that's oral amoxicillin. The second line we should consider as atypical infections, so azithromycin should be considered along with coamoxiclav or cefuroxime. And the anti-staphylococcal management is same as above age group. Now moving on to the IV antibiotic therapy. For less than 3 months age group, we should always remember that there should be a combination of both cephalosporins for both broad spectrum coverage as well as specifically gram-negative coverage with either amikacin or gentamicin. So we usually prefer ceftriaxone in our setting, or we can also use cefotaxime along with either of amikacin or gentamicin. For second line or for escalation, we can use either of piperacin tazobactam along with amikacin or cefoperazone sulbactam with amikacin. And for Staphylococcus aureus infection, just for the same instances as previously mentioned, like post-measles and rapid deterioration, we have to choose a combination therapy of ceftriaxone with a cloxacillin or either of vancomycin or linezolid based on the sensitivity pattern of the organism. For 3 months to 5 years age group, the first line is IV ampicillin, or we can also choose coamoxiclav based on the availability and on the hospital setting. So other alternatives are cefotaxime or ceftriaxone as the primary choice. And for Staph aureus, we have to choose again a combination with ceftriaxone with cloxacillin or clindamycin, linezolid, or vancomycin based on the sensitivity pattern. More than 5 years age group, the first line remains the same, IV ampicillin or coamoxiclav. For alternatives, just like oral therapy, we should consider azithromycin for mycoplasma coverage along with ceftriaxone or cefotaxime. Next slide. Here we are seeing for comparison the two causes of grunt as I mentioned before. So left side we have a case of the chest X-ray shows there is non-homogeneous density of opacity. We can make out a few air bronchograms to the arrow marks, and there is decreased lung volume, and the costophrenic angle is clear. So, but in contrast, the right side there is increased lung volume on the affected side, where there is complete whiteout homogeneous opacity, and there is obscured costophrenic angle. And so this indicates the left side is a pneumonia X-ray and the right side is it's an empyema X-ray. So which indicates that immediately the child needs intervention, confirmation with chest ultrasound and intervention by needle thoracentesis and intercostal drainage. So this is a comparison for right pneumonia and empyema. In this slide, can you play the video, please? We can see a small toddler child in respiratory distress getting resuscitated by a Bain circuit with the mask placed by the mother in her lap. So Bain circuit is just to put in contrast to the non-breathable mask which is shown in the picture to the right next to the video. So there's the difference is Bain circuit gives, along with higher oxygen support, it gives PEEP also. But similar to an NRF, it also uses high level of oxygen requirement, that's 10 to 15 liters. So this is an effective way of delivering the oxygen to a sick child before getting higher resuscitation. Next slide.
As Ismat said, if you are shifting a child with pneumonia or empyema to a tertiary care center, which may take 30 minutes, if you attach a Bain circuit or Jackson circuit, it will give a CPAP so that the child will comfortably land in place where I want to send as a referral care, which is commonly available, which earlier used only by anesthetists, now used by emergency pediatricians. The cost is around 500 to 600 rupees. It's a very useful equipment during referral. Next slide. Next slide. Not uncommonly, they may land up in an emergency. And Saranya.
A neighbor comes to us in a hurry saying he was eating groundnut. Now there is sudden onset of cough. There is no voice and the child is becoming blue. Then a complete airway obstruction is suspected. If the child is less than 1 year, we will be providing back slaps and chest thrusts. If the child is more than 1 year, we will be providing Heimlich's maneuver. We have recorded video for both, which we will be showing now. Infant boy was playing with his elder brother who was eating groundnut at his home. Mother suddenly noticed that the child started coughing and the child was turning blue and crying without any voice. She immediately rushed the child to a nearby pediatric clinic. In the clinic, the pediatrician noticed that the child had ineffective cough, ineffective respiratory effort, and cyanosis. Hence, complete obstruction was suspected and choking relieving maneuver was started. The doctor who is going to provide the choking relieving maneuver will sit with the infant on his lap. He will hold the infant face down with head slightly lower than the chest, resting on your forearm. Support the infant's head and jaw with your hand. Don't compress the soft tissues of the infant's throat. Rest your forearm on your lap or thigh to support the infant. You will deliver 5 back slaps forcefully between the infant's shoulder blade using the heel of your hand. After delivering 5 back slaps, place the free hand on the infant's back and turn the infant and provide 5 quick downward chest thrusts in the middle of the chest between the nipple line. After completion of 5 back slap and chest thrusts, the child's mouth is open and we will look for foreign body. If it is seen, remove with a finger sweep. If it is not seen, blind sweeping should not be done. If the foreign body is not expelled, we will repeat the sequence of 5 back slaps and 5 chest thrusts until the object is removed. If the infant becomes unresponsive any time during this maneuver, please start the arrest algorithm.
By providing CPR.
By providing
CPR. Okay.
Next, we will see a video where Heimlich's maneuver is performed. Child above 1 year experiences sudden choking spell. We will do Heimlich's maneuver. If you think someone is choking, ask, are you choking? If he not yes, keep telling you are going to help. Get behind him, wrap your arms around him so that your hands are in front. Make a fist with one hand, put the thumb side of your fist above the belly button, well below the breastbone. Grasp your fist with your other hand and give upward thrust into the belly. Give thrust until the object is forced out and he can breathe, cough, or stop.
At this point, I'd like to thank the Mr. Haribabu, is an emergency technician, trained emergency technician. He has very well demonstrated the adult Heimlich maneuver. Next slide.
Here in this scenario, a mother is hurrying to your clinic, shouting, "My child was having high fever. Now, and he was having noisy breathing, and he's not talking, did not taking feeds. He is being lethargic, and now he has stopped breathing." She is very much distressed and asks, "Please save my child. Please do something." When we receive the child in the ER, when we observe he is unresponsive, he is gasping for breath, or is he not breathing? Just next step is go check the pulse. If the pulse is absent, we have to go ahead with the pulseless arrest schema, that's CPR. And if there's a good pulse, we are going to give rescue breathing, which we'll be seeing in the next video. In situations when a child is brought in respiratory arrest, but there is good pulse, a good bag and mask ventilation can support and save the child until the child reaches the tertiary care center. We have to first, we have to open the airway by head tilt and chin lift. And to make a seal, this should be done in absence of cervical spine injury. We make a seal between the mask and the face, tilt the head back, and use the easy clamp technique. To lift the jaw against the mask, pressing against the face, and it seals the mask on the face. This technique moves the tongue away from the posterior pharynx and moves the jaw forward as well as opens the mouth. And with the other hand, as shown, we have to gently squeeze the bag to deliver the breath. And we have to make sure the chest rises. Until then, we have to keep bagging. So and in general, each breath has to be delivered over 1 second. And the rate of giving the bagging should be 15 to 20 breaths every minute. And definitely should remember that every time we have to look for an adequate chest rise with every breath. Avoid excessive ventilation. A good chest rise is the indication that we have given an effective and appropriate bag and mask ventilation.
This video is just to show how our pulse oximeter can be used.
Saranya, 1 minute.
Yes, sir.
Everyone should have 3 types of bag and mask. One is infant mask, child mask, and adult mask. And 3 types of ambu bag also must be available in all the clinic and smaller hospitals. 1 for the newborn and infant, 2nd for children, 3rd for the adults and adults. So unless we have a correct mask, that is nicely explained, you have to keep the mask, the upper margin should be in the root of nose, lower margin in the chin. That is the right mask. If the mask is not able to cover both nose and mouth, we have to go for the next level. So correct mask is availability. Correct mask is important for delivering proper ventilation. Over to Saranya.
We are showing how a pulse oximeter should be used.
In order to check the oxygen saturation using the pulse oximetry technique. Step 1, switch on the pulse oximeter. Next, we insert the finger into the probe. The saturation recorded here is 98% and the pulse rate is 79 per minute. We need to always wait for the waveform to appear before recording the saturation.
There are 2 points to say that our pulse oximeter is showing a correct reading. One is the presence of waveforms. Second is the rate shown by the pulse oximeter. The rate we check the pulse clinically, both should be same. Then only we can come to a conclusion that pulse oximeter is showing the right value. Over to Saranya.
Diksha?
Yes, sir. This is a 10-year-old girl who returned from school. She was walking through a paddy field and had a thorn prick-like feel. Her mother took her to a doctor and she had received tetanus toxoid. Next morning, she developed abdominal pain and could not stand up or walk. She also had double vision and weakness of both lower limbs. Deep tendon jerks showed hyporeflexia. She was taken to the ER of a multi-specialty hospital and the ED pediatrician felt Guillain-Barré syndrome as the first diagnosis, and then the neurologist was called. Her airway, there was noisy breathing, but she was stable after positioning and suctioning. On breathing, she had a shallow breathing and a respiratory rate of 20 per minute, and a single breath count was 10. She had a low voice volume and a weak cough, and a saturation of 94% in room air, but there was no paradoxical breathing. So bag mask ventilation was given, and for intubation, we were getting things organized. Coming on to circulation, her heart rate was 90 per minute with good pulse volume and regular rhythm. She had a blood pressure of 110 over 70 millimeters of mercury. IV access was obtained. Disability, there was eye contact which was present. Pupils were normal, equally reacting to light. She had a weak voice. She had bifacial weakness and ptosis was present. So this child is in respiratory failure. Next slide. As we can see in this picture, the child has drooping of the jaw and drooping of both the upper eyelids. So ptosis was present, and in her foot we can see the fang marks. And in her hand also we can see a similar mark. So playing the video. Here we can see shallow breathing. That is, we need to observe much closer to look at the movements of both the chest and the abdomen. So this diagnosis of snake bite was made, and this child improved after anti-snake venom was given and with ventilatory support. So this is the same child before and after therapy with ASV and supportive ventilation. The ptosis has resolved, and as you can see, she looks much better, and the drooping of the jaw has also stopped.
Of course, once we happen to see a child in crisis, we have to immediately attend oxygen and the back mask ventilation. Yeah, transport is the most important part based on which child will have a successful resuscitation. A pulse-trained doctor plus a pulse oximeter plus oxygen, ambu bag, bulb sucker, transporting in any vehicle, whether auto or a car, is equivalent to an emergency ambulance. We know that in a busy traffic like Chennai or even any other cities, getting an ambulance at time, even they are willing to come, is not easier. So whichever the vehicle, this will replace, I'm repeating again, a pulse-trained doctor plus pulse oximeter reading, oxygen, ambu bag, bulb sucker, transporting any vehicle is equivalent to an emergency ambulance. To safeguard ourselves, nowadays it's not easy. People are hostile with us. To safeguard ourselves, tell the parents loudly and clearly, and also to the onlookers, the child is in dying state. Stop the breathing. I am accompanying giving an artificial breath. I'm just telling the situation in a clinic, single clinic. I am accompanying the giving artificial breathing for the child. We will ship the child to higher center, preferably to the nearest center. If we do it, even there are 50 patients waiting. I know most of our colleagues will be seeing around 100 patients a day. Maybe some 50 patients waiting. But please forget about it. Go along with the child. Nearest center, take the child. People will definitely appreciate, even the 50 people who are waiting there will highly appreciate your gesture of accompanying a sick child. So ethically, legally, socially, our act will be approved. Next slide. So how much you are prepared? Most of you know the famous story, Tamil writer Sujata. One day he wrote in 70s, he wrote a short story saying that that particular hospital is Satyamaga emergency பார்ப்பதற்கு தயாராக இல்லை அப்படின்னு ஒரு வேர்ட் எழுதுவார். So to make yourself fit for receiving an emergency, what is needed? Are you prepared? Simple mnemonic is soap me. Yes, for suction device. If you have a suction apparatus or a bulb sucker or even daily suction catheter, maybe enough. Oxygen delivery. You can have oxygen cylinder. Nowadays, most of our colleagues have oxygen concentrator, which is available freely. And maintenance charge is also very less. And then airway adjuncts. Airway adjunct means armor bag, different types of mask, oxygen hood, oxygen mask, oxygen administration devices, and protocols, simple protocols, how to manage anaphylaxis. Like that. It will be very useful, how to manage seizures. Medicines, drugs like Metazolam may be available for IM injection before shifting the child with seizures. Because you can't get an IV, even if you're very good in IV access, in a single clinic without any help, you can't do that. So Metazolam IM may be a good alternative for that. And equipments, common equipments. Intraosseous needle, if it is available, suppose pulses are not felt, you can even start an intraosseous needle in a smaller hospital. Start an IV and shift the child is in shock. LMA is a very good alternative. The child is completely apneic and flaccid. Bag and mask very difficult to maintain contact during transport. The LMA is very easy to introduce and administer, which may be a very good option for extra hospital resuscitation of the respiratory effort. So these are all the equipments which must be available in our clinic and smaller hospitals. Particularly, Professor Namadwar used to say, if you give vaccines, the child develop anaphylaxis. Nobody can predict whether the child will develop anaphylaxis or not. If we have adrenaline injection, give adrenaline injection, bag mask ventilation, start an IV and shift. Even the child, you cannot save the child. You can boldly say that what else, anybody else could not have done anything better than this. Definitely our effort will be acknowledged. So these all should be present in our clinic as well as in smaller hospitals. Next slide. I'm just repeating the same slide. Probably Ismat can explain the slide.
So as we
Four
saw
steps.
the
Look
what
out
so there's a 4 steps. We have to first immediately lift the shirt of the child and count the RR for 30 seconds. And immediately pick up if there is any increased workup breathing that can be in the form of noisy breathing, retractions, nasal flaring, and what does the saturation say to you if it's a normal or it is child is needing oxygen support, or how is the altered mental status? So if there is only increased respiratory rate but workup breathing is normal, that's probably a case of effortless tachypnea. When the respiratory rate is increased and workup breathing is also increased, like in the form of retractions and LNSA, it is child isn't, but the sensorium is okay. The child isn't respiratory distress. And when it is combined with there is defective and there's altered mental status in the form of lethargy or unconsciousness and with fixed gaze, the child is in respiratory failure, which needs immediate intervention by ventilation, intubation or vagus ventilation.
I just want to reiterate the fact that once you touch a child will start crying. You can't count the respiratory rate. So better stay away, 1 or 2 feet away, just looking at the child, making some pleasant noise, offering a toy, count the rate. Otherwise, once you touch a child, put a step, child will cry, will immediately, importantly, you can't assess the rate and work up breathing. This is the last slide. It's a nice proverb. You are not given a problem without a power to solve it. I think no shops, only the locks are sold. Locks are always given with key. So for every problem, there is a solution for it. I've seen in my own lifetime, 1996, we attended the first PALS course in Chennai, Vasanthi Medical Center. 94, right? 94, myself, Dr. P. Ramachandran, Annamalai Vijayaraghavan, and Indumati all attended the first PALS course in India, 1994. 2 years later, nature gave us the dengue. Imagine, God has prepared us 2 years earlier to manage dengue, because prior to PALS, none of us will feel the pulse, count the respiratory rate, and look for noisy breathing. So the problem is a critical illness. What is the solution for that is PALS concept or IAP ALS concept. I request all the pediatricians to attend the course on IAP ALS course, which will teach us a lot of things for a meaningful inspection, deep inspection, and powerful inspection. Thank you very much for your patient listening. I'd like to thank the IAP Tamil Nadu State Chapter headed by Dr. Rajendran. At the same time, I like to thank my team members and Dr. Muhammad Ismat, Dr. Saranya Chandran, Dr. Sudiksha. Now all of you understand it's better always to have young people with us, because we are all old now, know how long our body will be very strong and do everything perfectly. When we have 3 youngsters, no, all of they'll be like captains, they'll do all the work. You can be a general and give orders. Thank you very much for your patient listening. We'll be very happy to answer questions from the audience. I also like to thank my teachers, Professor L.S., Professor Somu, and Dr. Krishna Kumari. Most of us have taught us how to identify a sick child. It's not a very easy thing. They imparted their knowledge to us at Namalwar. So many teachers imparted knowledge to us, and we are continuing the service by transmitting to our youngsters. So they let their knowledge spread everywhere. Thank you very much for your patient listening.
Yeah, remember Vasanthi Medical
Sanya,
Center.
stop sharing.
Vasanthi Medical Center, my classmate G. Srinivasan with Janaki Raman and all, they were there.
Yeah. Professor Janaki Raman was the first person to start PALS course in India. He was
G.
responsible
Srinivasan
for
was also there.
development of emergency and ICU in India.
Gopal Srinivasan in Chicago.
He was there for the first PALS course at Gopal Srinivasan.
Yes.
Thank you, sir. Everybody is very appreciative of this wonderful lecture and those brilliant videos and demonstrations. I think, as always, we are reminded of it's important to learn the basics rather than jumping on investigations. Otherwise, we will miss some critical diagnosis and the whole treatment can definitely go in the wrong direction. Doesn't look like there are very many questions, because I think everybody is well bound. But just now I just got a couple of think I'll invite a few comments from Professor Srinivasan sir and Professor P.R. sir before we close the. Srinivasan sir, P.R. sir, Jalil sir.
Hello, sir. Class 7.
Sir, Sangavil sir, உங்களுடைய எஃபர்ட்டை நாங்கள் எப்படி சார் பாராட்ட முடியும்? எப்படி எங்கள் வார்த்தையே இல்லை சார். நீங்கள் இவ்வளோ உடம்பு சரியில்லாமல் லெரிஞ்சைட்டிஸோட நான் ஒரு 2 மணி நேரமாக உங்கள் லெக்சரை கேட்குறேன். காட் இஸ் கிரேட் சார். எங்களுக்கு உங்கள் விஸ்டம் எங்களை விட இந்த ஜூனியர்ஸுக்கு இன்னும் ரொம்பவே நல்லா வந்துடுவாங்க சார். ஐ ஸ்டில் ரிமெம்பர் லைக் யூ, ஐ டிட் மை பால்ஸ் இன் KMCH. ஐ திங்க் 1996 நளினி மேடம் தான் வந்தாங்க எங்களுக்கு. அந்த பால்ஸ் அதுக்கப்புறம் தான் பால்ஸ் ட்ரெயினர் எல்லாம் அது பேசிக் இது ரொம்ப யூஸ்ஃபுல்லாக இருக்கும் சார். கான்ஃபிடென்ட் இருக்கும். ஸோ எக்ஸலண்ட் டீச்சிங் சார். இது கண்டினியூ ஆகணும். நம்ம ஃபியூச்சர் ஜெனரேஷன் வில் கெட் டெஃபினெட்லி மோட்டிவேட்டட். அண்ட் என்ன சொல்கிறது, வார்த்தையே இல்லை. நீங்கள் உடம்பு சரியில்லாமல் இந்த லெரிஞ்சைட்டிஸோட 2 hours நீங்கள் நான் ஸ்டாப்பாக நீங்கள் பண்ணிக்கிட்டே இருக்கீங்க. எனக்கு அதுதான் ஒரு மனசில் போட்டு உறுத்திக்கிட்டே இருந்தது. உண்மையாகவே சொல்கிறேன். ஐ வாஸ் ட்ராவலிங் ஃப்ரம் ஈரோடு டு கோயம்புத்தூர். செல்வமுடைய வெட்டிங் அட்டன் பண்ணிவிட்டு வீட்டில் இருக்கேன் சார். தேங்க்யூ ஸோ மச் சார். ஃபஸ்ட்டு லான்ச்சே பெஸ்ட்டு பண்ணிட்டீங்க சார்.
செல்வம் வெட்டிங்க, செல்வம் பையன் வெட்டிங்க.
செல்வம்
ரொம்ப உணர்ச்சிசப்பட்டார் சார் சாரோட பேசுகிறேன்
சார். யார் சார் அப்படி? நான் தெரியும் சார். இவ்வளவு லெரிஞ்சைட்டிஸோட எப்படி சார் பண்ண முடியும்?
Definitely.
Sir is finding difficult.
It's a phenomenon.
ஐயோ, God is great, sir.
The scientific part, everything was fantastic, sir. So it's very, very basic. What every one of us should revisit. Anala irundhude. But I just want to make nothing related to the science and subject. Enna coincidence? Thangavelu somehow chose respiratory and the airway problem, in spite of having a lot of airway problems. That is my first observation.
Okay.
Second observation is, he himself has put in the last slide. See the way he has engaged the junior, the excellent upcoming teachers, budding teachers, to take up the cudgel on his behalf. It not only is a long sight, a visionary. இன்னைக்கு அவருக்கு அது எவ்வளவு ஹெல்ப்ஃபுல்லா இருந்திருக்கு பாருங்க. He put the last slide, no? You are not given a problem without a power to solve it. He has already solved the problem of his laryngitis by engaging 3 brilliant juniors. So that's how the God has helped him also, and he has also planned things which always help him in good stead. So it is a privilege and great pleasure to learn and work with him. Best wishes for the future programs. Congratulations, IAP TNSC.
Thank you, sir. Srinivasan, sir.
Srinivasan, of course, is a great admirer of Thangavelu. So there are really no words, because everybody knows about him. And it'll be frivolous for me to talk about him, because his observation power and his interpretation power is something which is unbelievable. And of course, he has strong basics, as well as he is very strong in advanced intensive
We can talk about a subject, sir. Tell something about a subject rather than persons.
I am talking about your this thing, complete knowledge and how you are applying it.
Thank you,
sir.
Early detection.
Thank you, sir. Thank you very much, sir. I think we had a wonderful session. We're eagerly waiting for the next session coming up next month. So thank you, sir. And I think
thank you, sir. Sorry, through and sir, thank you, Dr. Thangavelu, sir.
Sorry,
ஒன்னும் இல்ல thank you. And sir, sorry, உங்களுடைய ஹெல்த் இவ்வளவு இருந்தும் ஏர்வே ப்ராப்ளம் இருந்து ஏர்வே நல்லா சக்சஸ்ஃபுல்லா எடுத்துட்டீங்க சார். Thank you, sir. Thank you very much. And really grateful to you, sir, on behalf of IAP TNSC. Really grateful to you. இதுதான் சார் உண்மையான டீச்சருக்கு என்ன அழகுங்கிறத நீங்க இன்னைக்கு பேச்சு மூலமா நிரூபிச்சிட்டீங்க சார். தேங்க்யூ. அதாவது எவ்வளவுதான் இஷ்யூ இருந்தாலும் இந்த ஸ்டூடெண்ட் சொல்லி கொடுக்கணும் ஒரு எண்ணம் இருக்கு இல்லையா, அது ஹேட்ஸ் அப் டு யூ சார். தேங்க்யூ வெரி மச். தேங்க்யூ வெரி மச் சார்.
Rajendran, last request. I request all the viewers to suggest topics. We have another 10 sessions in the 2025. So what topics you want us to discuss, please? you can send it to my WhatsApp number or send it to Rajendran or Thiru and Narmada so that it will be useful for us to choose the topic. Thank you very much for your patient listening.
Thank you, sir. Thank you very much, sir. Good night.
Thank you,
Good
sir.
night.
Thank you.
Good night.
Thank.